The YouTube one, yep.
Yeah, the premium or.
And you let me know with the Facebook. I think we are already live. So good afternoon. We are having our weekly event with United Medical ACO. Today I have a special guest from our local home state. She's going to be joining us in the next couple of minutes. And I will actually bring up my PowerPoint here. And all right, so now I am going to share my screen and we should be good. All right, now today is October 2nd. As you know by now, this is our, I believe, event number 10. We have done so many of these, and every time we do these, we learn more. And one of the things that we are trying to do is to limit the number of topics that we are going through. And that's where we are today. Now we are going to discuss the corona updates, and then we are going to also have the digital health platform update, which made it natural second, guess for us, not second guess, but natural choice to have Dr. Jan Lee to join us from DIN, because from the Delaware standpoint, digital health standpoint, DIN has probably the biggest role since the start of DIN. So before we go to that, I just want to give everyone a little background on United Medical. As everyone knows by now, we are not doing this event for any of the commercial bias. We are doing it for our existing patients and anyone who live in United States, obviously. But we don't have any commercial bias here. One of the things that we always point out is the triple aim is everyone heard already, and then in the last couple of weeks, I tried to emphasize the quadruple aim, and in the quadruple aim, other than improving health outcomes, lower cost, better patient experience, we add physician and physician practices into this mix. And as I said, mentioned earlier, Dr. Lee, Jan Lee from DIN is my guest today, and I'm gonna actually ask her to introduce herself.
Hello, everyone. I'm Jan Lee. I am a family practice physician by background. I spent 23 years on active duty in the Air Force before retiring. And my last assignment in the Air Force, to my surprise, was CIO of the Air Force Medical Service. I never expected to be there, but when I retired from the Air Force, I felt like the use of digital tools and health information technology really had a lot of promise to address some of the things that had frustrated me deeply as a practicing physician all those years. And so I kind of turned a corner in my career, stayed with health IT, and consider myself very blessed to now be the CEO of the Delaware Health Information Network, or DIN, as most people know it.
Well, thank you so much, Dr. Lee. What I'm going to do is I do want to give the update on the corona virus, like what we do from our provider meetings. I believe when I talked to you last time, I mentioned that we do update our providers on a weekly basis, 2 or 3 times based on their schedule. So what we have here is I usually include 4/15, which is April 15, where we were as of May 15, and then I add, which I'm going to bring the screen right now, is the not sure if this makes it kind of easier to see. So this is where we are as of today in United States. So I think the reason I'm doing it in this format, Dr. Lee, so that they can see the number being how much it's higher than where it was. Like this is from May 15, it was 1.5 million. Right now it's 7.5 million. And from the start, earlier, maybe a little bit later from the start of April, it was 1 million. So that's 7.5 times more than where we were 5 months ago. And the number of people who lost their lives is also 4 times higher. And these numbers are concerning, and we are trying to do our job from the medical practices standpoint, the other healthcare providers like yourself, the other places who can actually support us better, support us more, which we reach out to you guys, and then we do that. Now, when I'm going through this, I'm going to actually just do the Delaware numbers. Dr. Lee, I don't know if you have seen the last couple of days. The total number of positives, apparently it's increasing, the percentage. So like normally I do also share, even though this is public, everyone should have access to this. From the Delaware side, we do see the number of hospitalization, total hospitalization right now, that's 78, and then new hospitalization. But here's the one that I wanted to point out, and this number, the blue bar, is the 14-day average. So like we kind of stopped paying attention to the orange bar, because orange line, because it's really just what's reported that day, and the tests may be done in different days, so it doesn't really give us much. So we try to educate our providers and also our patients to make sure that they look at this 14-day average. So this number, the percentage is now at almost 8%. Now, I remember 2 months ago, we were around like 4%. So even, and one of the issues that we have in Delaware, like from the numbers that we get from United States, I think the number of total tests that we have done in 1 million is a little bit lower than the US average. So, but now this number is increasing, and I thought that was kind of interesting to point out, so that I think we need to be more careful with this. Do you have anything to add?
No, other than this was predictable, that with schools starting back up and the colleges opening up again, it was almost a given that this was going to happen. What I am relieved to see is that at least so far, the rate of growth is fairly shallow compared to the early days when everyone was worried about overwhelming the medical system. And we're very far from that at this point. But yes, any upward trend is concerning for sure.
Exactly. So now, I think when we bring digital health as a topic, and when we have our other meetings the other day, I'm like, well, it would be perfect if we can have Dr. Lee with us, because I have said this before, but maybe not in, I didn't maybe say publicly, but I want to take opportunity and say this. I think DIN, Delaware Health Information Network, is one of the best things that happened in healthcare landscape in Delaware, because the way that we were able to take advantage of our small state and being able to put all the data centers, and with the good leaders from your side, I think we have done a really good job, and I want to make sure that our providers, our patients do understand what DIN is and how actually it is part of the medical practices and hospitals and how it's helping the society. So I do want to thank you again for the work that DIN has done so far, and we are extremely happy to be part of it. Now this diagram, when I was explaining United Medical ACO, this is maybe from 2011, 2012, and then even then it was part of the main element of our data flow. And you have done a really good job in terms of how the how DIN actually position itself in the medical flow. So if you can give us a little bit background on DIN before we go to some of our questions, what DIN does and what it can do in the future and what the plans are, that would be great.
Sure. Well, our two core services are the things that I think most people think of when they think of DIN. One is results delivery. So as healthcare providers order labs and radiology studies and various things. The data providers send those results to us. We deliver them on behalf of the performing entity. And then we also archive a copy of that result, which enables us to provide the community health record, which is that portal that you can log into and view all of the aggregated results about a single patient from all care settings, all locations, whether it's a hospital, an emergency room, a lab, all of it gets aggregated and cataloged into one chart so that the full set of health data about a patient is available. Those are the two core services that DIN offers. There are a number of other services as well, and maybe we'll get into them, but those are the things I think most people know DIN for.
So since DIN was kind of already advanced from everyone else in the state, now with the unique challenges that we see from COVID pandemic, how that change your normal business practices?
Well, in some ways it's been business as usual, just a lot more of it. And there have also been some new things that we have embarked on as a result of COVID. The business as normal things are we are still delivering results to the ordering provider. So whether it's a COVID test or any other kind of test, if it is a normal order placed by a provider to one of the labs that is already affiliated with DIN, then those results come to us, we send them to the ordering provider, and we make that result also available in the community health record. So that hasn't changed. That's just normal stuff. The other thing that's just normal is we facilitate reporting to public health from our hospital labs of required syndromic surveillance and reportable lab results, COVID being one of those. So we've already had those interfaces with our hospitals for many years now, and it's just the volume going across those interfaces has greatly increased. But one of the things that has happened with the push to do widespread testing is more and more smaller labs are trying to get into the game. And so we are learning almost weekly that there is a new lab somewhere that is not a part of DIN that is embarked on coronavirus testing. And obviously, for the benefit of the entire medical community, we feel that it's very important to get those results into the community health record. So we're pursuing that on a couple of different angles. One is to work with the lab to try to get them to become a data sender. The other is working with public health. And this is a little bit of a backdoor, but we have worked with public health to say, when these labs report to you, will you please send those results to DIN so that we can deduplicate it if we've already got it and put it in the community health record if we don't already have it. Like I said, it's a backdoor. It takes a little bit longer, but eventually we do get those results and they go into the community health record, so they're accessible to the entire healthcare community. Another thing that's been just kind of business as usual is event notification. That's one of the additional services that we offer. So when a patient is admitted or discharged from a hospital or emergency department, the hospital sends us electronic notification, and we are then able to use that information to reach out to subscribing practices, ACOs, payers, what have you, and say, one of your patients on your panel was just discharged from the Christiana ED or from Bay Health, inpatient status. And to the degree that the hospitals provide us with the information, we can also say, this is what the discharge diagnosis was. And so it provides notification of COVID admissions or discharges to the extent that the hospital includes that information in the messages that they send to us. We've also seen growth in the use of a service that we call Clinical Gateway. That is intended more for population management rather than single patient management. In a sense, it's a form of results delivery, but at a population level. So the way this works is a hospital or an ACO provides us with a panel of patients that they want to receive results on. And it can either be send us everything you've got on these patients, or it can be send us these specific result types on these patients. So for example, ChristianaCare wants everything on the patients that they're providing care coordination for. Bay Health has said, we want A1C results. That's all. We just want A1C results. Until COVID came along and they said, we want COVID results too. So curiously, I personally had a COVID test done at a Christiana facility as a pre-procedure test. The results were back in a day. And the following day, I got a message from Bay Health saying, you have new results in your patient portal. I'm going, what the heck? I haven't had anything done at Bay Health. It was my COVID test that had come from Christiana to DEN, from DEN to Bay Health, from Bay Health into their portal. And then I, as the patient, got the notification that that result was available. So that was kind of nice to personally see that the cycle works, close the gap there.
No, I think the event notification also is really one of those that doesn't, maybe like perhaps the practices understands what it is, but we were one of the early adopters of event notification from United Medical ACO. And in the beginning, there were, like how we are coming up with the list, and it was the beginning of the ACO contracts. So, but in the last 3 years, we have we've been managing close to 60,000 members just from the roster directly with DIN. So our care coordination team actually receives messages on a daily basis. So we get the ER visits, the admissions, discharges, and then from the discharges, that's where we started transition of care, and then schedule those patients PCP follow-up. Mm-hmm. But that's why I was saying earlier, sometimes like, I don't know if everyone in Delaware understands how important DIN actually is and how much work you guys are doing with the medical practices for the patients. So I was trying to kind of go through different things that we do together. Just from the event notification is kind of like the data is already there, but we use DIN also for chart prep for medical practices. So if it's a brand new patient coming in, we want them to be able to see what's available for the doctor, especially now, Dr. Lee, the way that we have telemedicine. So I think the role of DIN is even greater because we want to make sure that we empower the providers with the data, and that only happens if we have access. So then we have, from United Medical ACO, we have, as you know, we have the logical domain where we are sharing our patient records with the treating physicians. However, we may not have access if there's a lab prior to us or someone else that patient went to. So we actually collect the data for the provider. This is medical offices doing it at the MA level the day before or 2 days before, and then we go into DIN, get whatever we have. So it does actually help greatly for the providers, especially who are doing telemedicine. Now, perhaps we kind of give away our next kind of question, but in terms of your help with the accountable care organizations and the health plans, one of the, my opinion on the patient portal or any type of patient access to their data, there is kind of like lack of interest almost, like they're not really just, it's there, but they don't use it. Is there anything DIN can do to actually increase the use of portals, patient portals? And it doesn't matter which one it is, as long as patient has access to it.
Right. Well, interestingly, people are very interested in portals when there's something there that they care very much about. So what we have found, and we've done some focus groups and market research on this that confirms what is logical, and that is the people that are most interested in using a patient portal are those who are trying to coordinate care for somebody else. So if you're coordinating care for a sick elderly relative or for a child, you're very interested in keeping up with all the results, especially if you are trying to track care of somebody who is seeing multiple providers. So often the case at later in life when somebody may have a primary care physician, but multiple specialists that they see for this and that. You know, CMS has estimated that on the average, a Medicare patient, so by definition, we're talking 65 and older, sees on the average 7 different providers every year. That's a lot of data to try to coordinate. And so those who are trying to manage care for someone else are very interested in being able to pull all of that together in one place. And so that is a great role for a patient portal. Now, here's the issue. If you have to go to a separate portal for each of those 7 providers that you see, that's a lot of navigate. That's still a lot of work to put on the shoulders of a patient. One of the things that DIN is trying to do to address this is to say, look, we can help in one of several different ways. If you already have a portal, which United Medical ACO does, how great would it be if your portal could connect with our data store so that when a patient logs into your portal, they get all of the data that DIN has about them. And we can do that through an API interface. The other way is for practices that do not yet have a portal and maybe don't have the technology expertise and don't really want to, dedicate the work that is involved in maintaining it, because it's not a start it and walk away. It does have to be maintained. DIN offers a patient portal or a personal health record that we can make available and even co-brand with a practice if that's desired, so that again, all the data that we have that the providers see in the community health record can also be made available to the patient from multiple different sources. Now, here's what we found. Adoption of the DIN patient portal has been very modest. We've been averaging maybe 10 to 15 new patient accounts a month for the last 4 years, until public health approached us and said, we are getting clobbered with phone calls from people wanting the results of their COVID test. And not only do they want to know the result, they need to have a printed copy, even if the results are negative, to show their employer so that they can go back to work. And we know that DIN has a patient portal. If we start directing patients to your patient portal, would that be a way that they could get access to their results and print them? We said, well, we'll have to do a little bit of a work on that, because there's some things that we'll have to change. For one thing, we have always imposed a 96-hour delay between when a result hits our data store and when we expose it to patients in the portal, because we want to make sure that the ordering provider has ample opportunity to make first contact with the patient if there's anything sensitive or upsetting about that result. So nobody benefits from a delay in COVID, though. So we had to selectively remove that 96-hour delay just for COVID test results. But what we found was that in 3 days, our total enrollment in the patient portal had increased 1.5 times over what it had been for the previous 4 years combined. So I guess the take-home message in that is, if there is a hot issue that people are interested in, and that's the way they can get the data, they will engage. They absolutely will engage. That's
a really good point. And as you were explaining this, I just had this idea where between the portals, like if, let's say, United Medical ACO portal communicates with DIN at the portal level, or if the patient's on your side and then they're coming to us for any reason. I was thinking maybe if at the primary care level, if we are able to identify their EMR vendor in that case. Like, for example, if one of our PCPs in the system is entered as, like, we use Cerner, so then that way maybe it can be kind of like hub from the PCP level going into the EMR of the ACO or EMR, and then stay with the DIN portal, so that those two can maybe communicate through that common element of the PCP. I mean, if we, like, right now when we work with Nevinet and Availity, they ask the PCP, the provider's EMR. So then they are actually, I think, building that based on how they are going to communicate with us. These are the insurance eligibility and claim portals. At Blue Cross, they use different ones from that point. But I think that's something that you and I, we can discuss after this meeting for sure. Now, my next question you actually answered, it was related to the COVID test. So that was one of the, I mean, our goal was to kind of have a dialogue rather than just questions, answers. So that kind of worked out really nice. One of the things that I see, the way that we can actually increase the patient's health literacy and what each organization can do. Now, what we have done so far, like, this is actually, these are our people, they're in different offices. For a couple months in the beginning, we worked from home, and then now we are back to the office, but medical practices had to stay open. So we started doing a lot of video events. And this Facebook Live is today, and the YouTube Live that we are doing today. The reason what drove that was how can we actually help patients, especially when they have limited access to us. And we are trying to actually, like, this is our YouTube page, like so many different events that we have done. A lot of physicians are joining me, and we, like, 1 week we did cardiology, 1 week we did bariatric, endo, diabetes type of specialties. Our social worker from the behavioral health side, she's on, our dietitians are on. And then one of the things that I thought it would be important for patients to actually easily kind of go through what we have available, if we have a good organized playlist. Now, for example, for this event, these are the different topics that we have discussed in the last several weeks. And then this will be added to that, where, it's kind of like really nice to make this available to the patient. Now, we do this from the let me see, actually, from the bariatric side for our bariatric program with one of the doctors, usually Dr. Irga joins me, and that event actually twice a week it happens. So we kind of try to take advantage of this crisis in a way that how can we actually turn this into an opportunity? Now, do you have any suggestions for patients to take advantage of these types of events, or do you have any suggestions for us that we can do differently to reach out to the patients?
Well, I think a lot of what I would suggest, I know that United Medical is already doing. First of all, you got to have a web page. You just have to, and you need to keep it current, because it's so easy for it to languish, and then you find that information gets very stale. So that's going to be the case with almost anything digital that I would mention. Is it's not enough to stand it up, it has to be maintained. But that's sort of the first, and the price of entry is you've got to have a website. I would say that you also need to have a social media engagement. And again, you're doing that with your Facebook and YouTube. DIN has, and it's not me, because thank goodness I've got smarter people than me who do this, but we are with LinkedIn, and that's more for the professional community, less about the patients. But Facebook, Instagram, Twitter, and we are working hard to sort of become an echo chamber for well curated factual information about COVID. There's just so much misinformation out there, and we want to make sure that whatever is coming through us it is well vetted and is sound scientifically. So I think that's another thing. Boy, when it comes from a patient's doctor, that is a sacred, special relationship that nothing else equals. And when their doctor says this, that, or the other, it just resonates in a different way than if CDC says it or anybody else says it. So using Twitter or other social media engagement platforms can be just a great way of amplifying messages that are already out there, but with your fingerprints on them. The other things, you can send out digital newsletters. There's just a range of things. And this type of event that we're having today is a wonderful example. I love what you said, Kemal, about what can we do to actually take advantage of this situation that we're in. I'm going to quote somebody recently who said, "Never let a good crisis go to waste." And I think we have seen some certainly some tragedies in the midst of this crisis, but we've also seen some marvelous innovation and some marvelous acceleration of things like telehealth and the use of digital tools to connect to patients. So there is a silver lining in all of this, and I think there's real opportunities there for those who are ready to be creative about it.
So, Dr. Lee, I wasn't actually going to bring this up, but the discussion actually is so great, so that I do want to share this with you. Last night in our provider meeting with United Medical ACO, I was actually talking to them about this. The issue of the flu season, and now this year, of course, with the COVID-19, it became a different picture altogether. But one really important thing that we start doing altogether, we actually start doing the telemedicine, telehealth, so which actually kept our patients home. We did that mainly for COVID infection, but the part that I was thinking that maybe the silver lining again is we know that every year so many people are dying from flu, and most of them are elderlies from this. Now this picture, the website is from CDC. What I'm sharing with you is in the flu season, how many people are actually going through different visits that they have. Let me see, I think it's about 21 million, if I'm not mistaken. 21 million visits are flu-related visits that they have. So if this year, that was a projection, so the 21 million visits, and it's almost like 60,000 number of people would die from flu, not the COVID, this is before COVID. Now, if we are able to keep the medical visits telehealth, I think we may be able to see the advantage of that in this projection of almost 62,000. The range actually goes from 24 to 62, and then it was in one of the other diagrams, it was up to like 90,000. So they don't know what that number is, just give that big range. But I'm hoping that if our Medicare population, especially if they can follow through the telehealth, get engaged with their patient portal, and understand these events and videos that we do on the clinical side to educate them, support them more, I think we can hopefully maybe save a lot of people from this side of the flu side of the equation. I mean, I'm not saying that it's like this is some kind of like give and take, but I think this would be a good advantage of managing those individuals in that patient population, I'm hoping. But when I actually was discussing this, usually I discuss with my leadership team here, and the responses, they understood what I was talking about. But what do you think about that? Like, I think if we can keep them home, the results would be better.
I do agree. I mean, with any highly infectious disease, and flu certainly qualifies as well as coronavirus, the more mixing of the population, the more the spread, right? So the secret to it all is isolate yourself from contact with well people and take the proper care of yourself at home. Well, if we can keep patients at home, then that reduces the spread. So I totally agree with your premise that we can not only impact COVID at this moment in time, but there's great potential for the future in the growth of telehealth and what that'll do for us.
Well, thank you so much again. Now, Dr. Lee, I usually tell our audience what's coming up next week. So I have 2 events. My next event is with Dr. Mike Peters from CRIAS. We are going to talk about the potential bariatric complications after the bariatric surgery. And then the Friday next week, this time, Dr. Jen Liquido from United Medical Clinic, she's a pediatrician. She'll be joining me for the pediatric-related issues with their school reopening and what parents actually can do in different ways to support their kids. Like they're already challenged with this whole issue where the kids can go home, can go to school, and they have work to do, and some jobs are not able to be done at home. So there are a lot of issues I think that people are going through. So we invited our pediatricians to talk to us on those items. Well, this was extremely enjoyable for me, Dr. Lee. Thank you for joining me. Do you have anything to add before we close?
No, but thank you very much for having me, and stay safe.
Thank you so much again. Bye-bye.
Bye-bye.